All right, we're going to go ahead and get started with our 3 o'clock speaker, Ildemaro González.
All right, everyone. Good afternoon. How's the conference going? Good? All right, so I hear that I'm the one standing between an exciting risk and legal presentation and then these baskets over here. So we're going to make it very interactive. So if you think I'm going to be doing the work, you're wrong. So the first thing I need to understand is, does everyone have access to a white sheet of paper or a sheet of paper? And what can you, as we talk throughout the next hour or 45 minutes or so, try to get your hands on a piece of paper, any color, it doesn't matter. All right, and a writing utensil, a pen or a pencil. All right, so I'm Ildemaro González. I'm Emory Healthcare's Chief Diversity, Equity, and Inclusion Officer and the Winship Cancer Institute's Chief Diversity, Equity, and Inclusion Officer. Prior to arriving at Emory and subsequently to Winship about a year and a half ago, I was at Dana-Farber in Boston, and prior to that at Parkland Health and Hospital System in Dallas. But my proudest accomplishment is I'm a dad of 2 men and married to my 6th grade sweetheart. How about that? And the trick is, we've been together since 7th grade. She was in 6th and I was in 7th. So let's talk about DEI. So when we talk about DEI, what are we going to talk about? Can someone shout out 3 words? We're going to talk about diversity, equity, and inclusion. What words come to mind? Equity, what else? Well, inclusion, yeah, all right. And also diversity. In addition to those 3 words, what else comes to mind? Culture, what else? Fairness, what else? Sorry? Gender? Sense of belonging. We're all in this together, and we're going to talk about all that, and we're also going to talk about cost savings. We're going to talk about business outcomes. We're going to talk about patient outcomes. We're going to talk about all that, because if we're really doing DEI the right way, in a comprehensive way, all these outcomes, all these results should be impacted, and hopefully you'll leave here today understanding a little bit more of what you already know, by the way. So today's objective, right? Examining the business case for DEI, discussing bias and micro inequities. Oh my God, Ildemaro, another class on bias. How many of you have taken the online bias class for Emory Healthcare? The one that I show up in a little video somewhere in there? All right, that gives me a cue not to repeat myself. And then we're going to summarize the Winship's approach to DEI, what we're doing, and we're actually going to start there. I have no disclosures, and when we think about why we do DEI at Winship, for us, it's a clear statement, right? DEI strengthens our research, builds a thriving team, enhances patient outcomes and experience, and leads to healthy communities. Now, that sounds pretty good, but is it true? So let's talk a little bit about some of the articles. And in a recent article, what I love, last year's New England Journal of Medicine, what I like about this article is we all know that when you increase the diversity in clinical trial participants, right, all those trials we do at Winship, when we increase the diversity of trial participants, we're more likely to be able to generalize the findings. So that's when we talk about biomedical knowledge, right? We can generalize it. Why? Because we've tested and we've done the trial across multiple populations, and I'll give you examples later. But this one, what I liked about this article that I'm quoting today is the fact that it leads to also to increased trust. And they did this very cool experiment, right? So they gave black men, they gave them trial results for a hypertension drug. They were all suffering hypertension. They gave him trial results for a hypertension drug, and they gave him 2 sets of results from 2 trials. One in which they were telling them, and it was clear, that there were 15% of those participating in the trial were African American, and in the other one, it was less than 1%. The group that got the one that had said 15% African Americans participated in the trial was 30% more likely to actually go on and take the drug and increase the trust in clinical. So while we generally speaking, we think about diversifying the clinical trial so it's applicable to everyone, I'd really like for us to start thinking about this issue of building trust. Because you know what? You actually were thinking about my community when you were doing this. Two quick examples, or one quick example. When Gleevec was being brought to market, and this is a story related to me by one of the researchers on the team that worked in a prior organization with me, he said, hey, when we were bringing Gleevec to market, and everyone, the world was loving the drug. Everyone truly appreciated what was going on. Except a month later, we get a call from Japan, right? A hospital in Japan, and they tell us, your drug is too toxic. It's not going well here. And they were surprised because everywhere else, it was going great. And what had happened was, so he gets on a plane, goes to Japan. They take him to a ward where those community wards where there's basically all the patients on Gleevec were there. And he sees everyone swollen. Like, Well, 2 weeks later, they find out that the high consumption of sodium in the Japanese diet was interacting with Gleevec, and patients were retaining fluid. Then he said, had we tested this population or this kind of diet, we could have anticipated this. So that's a quick example. But if you want to know a more simple example, when seatbelts were coming out to market, guess what? They realized, women tend to get more hurt in accidents now than men. Well, they went back and checked years later. They understood that all the tests for the seatbelts were being done with a male dummy with an average weight for males, right? And phenotype for males. So they weren't testing this for the two passengers that are likely to go in the car. That's a little bit of what happens when you don't diversify clinical trials, right? All right, so then thriving teams. And we heard, right, sense of belonging, and if I feel I belong, I'm more likely to express my opinions, right? Especially when they defer to from the leader's opinion, right? So we heard that sense of belonging. We heard innovation. How many of you have heard diverse teams are more innovative or more productive or so on and so forth? Just by a show of hand, ever in your life. Have you ever heard that? All right. Well, we'll check. There's a half true in there. But my point in this is we at Emory, 71% of our employees identify as African American, Hispanics, or Asian. And our teams are already diverse. So we really need to do this more to ensure we're not in the lower end of productivity and disengagement than anything else. Right, patient outcomes and patient experience. We'll tell you, I'll give you an example, but ultimately evidence-based DEI practices increase outcomes and experience for patients. And we know, for example, that patients that see a clinician or provider that is race or language concordant, right, the same race or the same language, get better interpersonal care, increased likelihood of meeting follow-up appointments, right, and increased adherence to treatment plan. It all comes down to trust. I trust the person on the other side who's giving me instructions. I'm more willing to do it. All right, so, and lastly, in terms of, so I forgot to do all these animations that were supposed to be so cool. All right, so then in the health equity piece, I'll also tell you a little bit about, as we are now collecting social determinants of health, and we're getting there. We have about between 50 and 60, depending on what you look at. If it's inpatient data, if it's ambulatory, it's not there in any ways. But understanding and addressing social determinants of health would lead to healthy communities, and over the course of the conversation, we might get into it. So this is what I was talking about, performance. So let me see if I can do this here better. We've all heard that diverse teams outperform and out-innovate homogeneous teams, right? And this is this side of the graph, the far right, right? However, the article that came out with this in the year 2000, that's the headline that everyone grabbed onto. The same article says, but wait a minute, it's not that they're diverse. It's actually diverse teams managed well, because diverse teams managed poorly are right here, are least productive than any other team, even those that are homogeneous. And it kind of makes sense, right? If you're in a diverse team, which all of our teams are already diverse, very likely based on our overall demographics, right? If you're in a team where the leader, right, they're capable of ensuring that everyone's voice is heard, that everyone feels that people know them, that there's an individualized experience in my team. I can, people recognize my ideas, they know it's something I said, so on and so forth. I'm more likely then to put that extra effort to contribute my opinions. But if I'm in a team where we all have differing opinions and no one's organizing this and no one's making us feel like we're part of something together, right? We're going to take more time to come to an agreement. Because let's say we all came from the same university, the same program during the same year. We'll more likely have certain parameters that would allow us to come to a decision or to a common frame of reference really quick, just to not use a race or ethnicity analogy here as always. So that's what this is. So if you've taken a nugget from today so far, it's not about diversity. We need diversity, but we need inclusion. We need belonging. That's what creates that extra effort. That's what is realized is, you've heard, hey, organizations that have more women in the board outperform their NASDAQ peers in their stock pricing, right? You've heard organizations that are diverse take products and services quicker to market, so on and so forth. It only happens not just because of the diversity, it's about the inclusion. So when we think about patients, right, and I told you, let's talk about patient outcomes. What you see here is a test that we did. So Shisha Kumar and Courtney Myers, two of our surgeons, oncology surgeons, right? They looked into data from our patients. These are patients going for GI elective surgery at Emory. So this is not all national studies support this. I like to share data from our own because people tend to think, oh, that would never happen in our hospital. That would never happen with us. That's somewhere else. So our patients going to GI elective surgery that do not speak English are taking almost 3 days longer in the hospital. And what happens if you're 3 days longer in the hospital and you don't really need to be? What happens? Cost goes up. What else? Infection, right? Risk of infection. All the classic hotties, all of that increases. And this is 3 more days. So just to think and to tie DEI to business outcomes and cost savings and all of that for a minute, we've tied it to the patient outcomes with the infection rates and all of that. Just to tie it with business outcomes, take a look. In that study for that period, there were 43 patients that didn't speak English and were taking almost 3 days longer. At an average $1,300, and I'm not looking at the screen, but I think it's $1,350 if it says there. So around $1,300, right? That's almost, what was it? Almost $160,000 in cost. Now, take a guess. How many patients in Epic tell us they don't speak English? How many? Lots, right? It's 23,000, and we don't think the data we think it's underreported. And you know how many tell us that they definitely need an interpreter to talk to us? 13,000. So these 160,000 can immediately multiply 10 times. Just to give you an example, we had a patient waiting, and I'm trying not to divulge too much so that we don't identify the patient, but waiting on a heart transplant, needing 2 interpreters 24 hours a day, right? You know the cost of that service per week? $47,000. The patient's been in the hospital 2.5 months, right? So when we think about DEI, this is what we need to think. We need to think about, you know what, when I see a patient, and this is a study we did at Dana-Farber, and I don't think they've published yet. But I was there while we were doing it with Ricky, one of the researchers there, and he understood. He asked, right, providers, nurses, and physicians, and we heard from nurses and physicians that when they know the patient doesn't speak English, and they're having a hard time getting the interpreter, eventually, if the patient is in the room for more than a day, there is a point where they stop trying to build a relationship with the patient. Because you know what? It's too hard. Think about it. Have you ever found yourself, I know that to talk up to this patient, I need an interpreter. It takes forever to get an interpreter. Have you ever been in this situation when you're rounding, when someone's rounding? Are we rounding with an interpreter so the person that doesn't speak English understands the shift side, the bedside shift change conference and all of those? So this is a little bit of how it impacts us. And lastly, to the business side of it, just to give you a thought, Forsyth County is the fastest growing, or has the fastest growing Asian population in the country. And in the last 10 years, not 50 or 60, in the last 10 years from 2010 to 2020, it quadrupled, and it's now nearly 20%. It's really about 18% of Asian American population in Forsyth County. Gwinnett County is also the second fastest rate for Asian Americans growth within Georgia. Right? And we have a hospital, and we have a Winship building where? Johns Creek. Johns Creek is at the border of these two counties, and that's where these patients are going. So what's the opportunity for us? If you're a business leader there, what are you thinking? What do you do with this information? Sorry? The time where everyone at a unison says something. All right, if you are a leader there or someone, you're thinking, how can I create loyalty? How can I be the first to embrace this community? So as the community grows, they come to me. Because Northside is wanting them. Piedmont is needing them. So on and so forth, right? So in particular, when populations are new to an area, they really word of mouth is how they take their services, because you've already tested it. So first, you're trying to do great things to impress. You're part of the community. You go in, you're volunteering. You're a member of so many of the community boards and so on and so forth. And which is the case at Johns Creek. Johns Creek is the one hospital that has a Korean interpreter that is in person, that it's live. And I'd argue that one is not enough, but well, they have one, right? And at Johns Creek, when you go to Johns Creek, during Lunar New Year or Diwali or any of those celebrations, right, that are from an Asian culture, they're celebrating it. They're celebrating it bigger than any of our other hospitals. But guess what? If you're a patient at Johns Creek and you need an interpreter, if you're in the hospital, you get that in-person interpreter. But if you go to the Winship Tower, you lose that ability, and now you got to go to the phones or the video. So what happens to the patient experience, right? So this is the kind of thing. We want to be the first movers advantage. We want to, and why do we want to? Have you all heard about how so in the last 3 years, prior to 2023, prior to 2024 fiscal year, in the last 3 years, we'd lost as a system $700 million during COVID and the 2 years afterwards, right? You've heard that because we update everyone on these things. And now, we're about almost 380 million positive to budget. So this is the kind of thing when people tell me, so do we really need DEI? We're already so diverse. I mean, look around. What do you think? Do we really need to work on DEI? All right. So that's why when we think at Winship, when we think about our plan, right, we want to make sure we weave DEI across everything we do. And with that, we put together a team of colleagues. We came up with these 5 goals there around becoming a national leader in cancer health disparities research and participation of underrepresented groups in clinical trials. That was a mouthful. All right. Fostering a culture of belonging, providing an inclusive and equitable and supportive experience to our patients, and developing the strategic partnerships to expand cancer prevention, early detection, treatment, and care. We've defined specific metrics. So we know how we're going to know if we're successful. And we've developed, don't worry about reading this. This was just to wake you up at 3:30. And we have defined actions for over the next 3 years. So when you look at year 1, this is a close-in shot of this. Yeah, we're talking about, and we've established already, Teresa Gillespie's full on board with a task to identify barriers. Why are people, what kind of limitations do individuals have to come to our clinical trials, creating an inventory of anything that is going on, providing education and resources, DEI education and resources to work effectively with patients of all backgrounds, right? So what used to be called cultural competence, now cultural humility, so on and so forth. How do we know right? How do we triangulate the Hispanic families, like my family? We go to the hospital in groups. Dad's coming to the hospital, we all go to the hospital, right? And rather than being frustrated as a provider, as a nurse or anything, how do I leverage this? How do I take this to my advantage? Because you know what? When you're talking to my dad, it does not matter if you're talking his language and he's got your full attention. He is always thinking, if I miss something, Ilde is going to get it, or Patricia, my sister, or someone, from the conversation. So whenever you ask him, do you understand? He'll say yes. He's not ever going to say no, even if after you leave he says, what did they say? All right, so don't be frustrated, leverage it. There was a study there was a practice, it wasn't a study, where they needed patients to send in H1C scores, right, while they were not in the hospital, right, and they weren't sending them in. So what they did was, at least at Parkland, like the majority of people in the diabetes prevention program were Hispanics, what they did was they asked everyone to come in with someone that they cared about. Just come in with a friend. And they said, all right, Jose, you're Mario's friend. Jose, Mario needs to send us this information. We need you to help Mario send us this information. They saw an uptick of around 70% in getting the information. So don't fight it. Leverage what you see that seems different from what you're used to every day. All right, so in part of this education, we talk about bias, and we talk about bias because it impacts everything we do. But let me, before even we're going to talk about bias, here's another one of those fun moments. Let's do a visualization. Close your eyes for a minute if you feel comfortable. Just get to that place where it's easy for you to do a visualization exercise, right? And you're going to feel and sense and see what I'm telling you you're seeing. So we tell you tomorrow you're going to go get an award in New York on behalf of Winship, right? Or your institution for those colleagues that are not from Winship. You're going to go get that award, and it's because how we have leveraged technology to maximize patient outcomes. So it's actually a tech conference, and the CEO of the hottest tech organization is going to be the keynote speaker, and you, Suzie, you, Jennifer, you are going to be the one getting the award on behalf of Winship, right? So it's 3 o'clock and you got to get on a flight at 6 today. So you got to go on and get out of here, run to your house, get things. So you're running, right? And by the way, we gave you a ticket, you have a car waiting, and you get to the airport, you get to Hartsfield-Jackson, and what you see when you get there is this. Look at the screen. Are you thinking you're going to make the flight? You're like, oh my God, I'm not going to make this flight. So you start running right through security, right? And as you get through security, you start hearing your name called. Mario, Suzie, Jennifer, our door's about. This is the last call for a flight to New York. We're waiting for you. And you're running through the gate, and you're seeing on your peripheral vision, you're seeing the storefronts just fly by. Once you see finally the gate, you see the gate agent, and you get there, the gate agent's holding their hand up. You give them the thing, the phone, they do, you run in, and once you run in, you get on the plane, and the pilot comes out. Don't worry, you've made it. I'll have you in New York in no time. Just go ahead, go back, take your seat, and relax and enjoy your flight. You look at the pilot, you smile, right? Are you looking at the pilot and smiling? You look at your pilot, you smile, you go, oh my God, I thought I was making everyone late, and I would have missed this, so let me go ahead and sit down. You go ahead, you sit down, you land in New York, get to your hotel. As you're checking in, you're starving now because I saw a lot of you eating gummy bears, but that was about it. So, right, you ask the person at the counter, hey, is there a restaurant near? Oh yeah, we have a lovely restaurant here. You don't even have to go out. Go, 2 doors down, boom. You get to the restaurant, you get a drink, and it's water. All right, you get a drink and you're celebrating and whatever that you made it. And you turn around and you see a couple celebrating their anniversary. You see them, you cheer them, you smile, you get back to your meal, you finish your meal, you go to your room, you get up the next day, and you get to the conference. And you are all excited because now the CEO of that tech company is coming out to the podium, and you know you're going to have to go up and pick up that award. And the CEO gets up and starts their keynote. That's when you open your eyes. And now, this long exercise was to ask you 3 simple questions. when you looked at the pilot? Was it a black woman? Oh, and that couple celebrating the award, their anniversary. Was it a same-sex couple? You don't have to answer out loud, but just think through this. And lastly, the keynote. Was it a woman in a wheelchair, the keynote of that tech company? So hold your thought in there. Reflect. When we think and when we talk about bias, we're talking about those quick associations that are made in our brain. We're not telling you you're a racist. There are some race-based biases, and we'll see in a minute there are many other types of biases. But think of them as associations, and that's why we say everyone has them. Because it's a quick association as to when you hear, oh my God, this patient. When someone tells you, you know, they're a frequent flyer, or, oh Lord, this is the patient that's been ringing the bell all night, or whatever. Immediately something comes to mind. Or if I would ask you, who is your perfect patient? What do they look like? Close your eyes. You have someone in mind. Right? Those associations is what gets in the way of equitable care, right? So, at the end, what are we talking about? It's, again, I like the definition of it's a shortcut of the brain, but if you want a more formal one, it's attitudes and stereotypes that affect your understanding, actions and decisions. Because we take actions based on those. We make decisions based on our biases, right? And how are they formed? I'll tell you, a lot of mine are formed from my family. Growing up with my mother, they tend to be, right, the media exposure, where you grew up, what you hear over the dinner table, so on and so forth. My mother would always tell me, Ilde, if you don't behave, I'm going to call the police. So when I was 30 and I moved to the United States and kids were like, hey, if you get lost, go and look for a police officer in a mall. I'm terrified of police, and I really didn't know it until I started driving or when I started traveling internationally. And every time I would go up to the immigration desk, I'd start shaking. And what happens to a Hispanic short guy, you know, that comes in? Hey, the officer's like, hello, where are you coming to the U.S. for? Oh, I work here. Where do you work? Oh, at Emory. Really? And that's true. And then you start shaking, and then as you start shaking, they start being more inquisitive because it's not a good sign. And that's when I realized this is what years of this did to me. Now, my cousin, his mother would say, if you don't behave, my Aunt Miriam, she would say, if you don't behave, I'm going to put you in the garbage truck when the garbage truck comes by. I don't know what happens to him every Wednesday and Thursdays when the thing, but it's something like that, right? So at the end of the day, they're not always based on accurate information. They're formed through repeated exposure, and they don't align to our intentions. As I said, there are multiple that could be based on race, gender, age, socioeconomic status, weight, smells. Oh my God. Oh, I'll tell you in a little bit another one. Even when we're promoting our Emory Now appointments and all of that, people are biased because of that. All right. If you want to learn a little bit more, there are these implicit association tests by the Harvard Implicit Association Test Project, right? You can take them. How many of you have ever taken one of these? If you Google them, and have you done something different after you took them? Okay. So go ahead and take them. Get exposed to it so that you can understand, where you're at. Now, again, the best intentions, and I might not be intending to hurt you. I might not be intending, like in one of our ER rooms when someone came in, transported by an ambulance, they came in a wheelchair, they go in, and blah, blah, they move them to a wheelchair. The person is sat on the waiting room. One of our colleagues comes over and says, they're fine, they're just a little, under the influence or whatever. So they make the person wait. This is a true story. They make the person wait. Person falls off the chair. Other patients come to the counter, to the desk. I know that's how we call it. They said, hey, you guys got to go check on this person. Oh, don't worry, they're fine. 30 minutes later, I think you guys got to go check on the person. She fell again from the chair. Don't worry, she's fine. The patient died. all right? And it was because many things, this is probably an active litigation still, so I probably shouldn't even be talking about this, but it was about many things. But ultimately, whatever process we have humans doing the processes that immediately make the decision, oh, I've seen this case too many times, I know what it is, they can wait. The same skills that help you triage as a nurse are the same skills that if you don't stop to ask yourself for a minute something, can lead to events like that. All right? So does it matter? Is it boring to take so many classes in bias? It is boring, I'll tell you that. And we know, worst of all, we know bias training doesn't work. You know what works? Understanding the impact of bias. Studies tell us that, I'm already ahead like 3 slides, but studies tell us that, right, the effects of anything that you're doing on all the frameworks lasts hours to days, not more. So you got to consistently remind yourself of the impacts so that you look out for it. All right, I'll tell you, we've heard a lot about bias and you've seen them. If you're a Latino, you get less pain medication. If you are an elderly woman, you get fewer life-saving interventions. You're given more mentorship if you're a male, right, and you're applying for a lab job. Look, if you're an obese child, your teacher is more likely to assume you're less intelligent than if you were slim. If you're a black student, you're more likely to be punished than a white student behaving the same way. All these things, you can, and all, by the way, all these links, if you get the PowerPoint, all these links are linked to the article and so on and so forth. But bias impacts everything we do. All right, this is a study done with nurses and pain medication, and ultimately, the study's conclusion is that nurses gave higher doses of pain medication to females than males, and the analysis of the data tended to validate that it was biased about how men can tough it out and females need more pain medication. Now, if you asked my wife, she would tell you, hell no, because you're a wimp, all right? But the study, that was the conclusion. All right, so I told you this, I told you already that bias doesn't work. So let me share a little bit. All right, Ildemaro, you said it doesn't work, so what do we do? Why are you spending all this time with us? The first thing you got to do is recognize we have biases. And again, it's not about being racist. It's their associations. If I get that email from this colleague that writes 8 paragraphs in an email as opposed to a meeting, I'm already, another email from this person. What are they trying to say? Those are the associations. So first, recognize you have them. 2, develop the capacity, like put a flashlight on yourself. Be curious about yourself. Why? That actually will create a little pause in your brain, and that will enable you to see the actual facts, which is actually what you want to do in this practicing constructive uncertainty, and that's where we're going to hone in for a minute. Exploring awkwardness, engaging with people that you consider others, and getting feedback. Those are the common things, right? Oh no, get into someone else's shoes and go ask individuals. Well, we're more likely not to ask, and if we are asking someone, am I biased? No one's going to respond to you, right? Hey, am I biased? If I tell you the truth and you're my boss, I don't know how that's going to work out for me, right? If I tell you the truth and then you're my wife, I know how it's going to work out for me. So I don't tell you anything. So it's how you get into these conversations, getting into someone else's shoes, very, very likely not to actually work on a long term. But if you can experience that, volunteering, so on and so forth, it's effective. The one I think we should all remember, it's this aspect of taking a pause. You just take a pause, right? And it's got multiple steps. You don't even need to remember the steps. Just remember to take a pause so you break that ladder of inference in your brain. You're going to pay attention to the P here of what's actually happening. So let me look at the woman in the chair, right? Let me understand. Let me at least take the vitals. I'll try to understand what's happening, right? Acknowledge your own reactions. Understand what else could have been, all right? And then search for what is it that we can do with this. And I'll give you an example. Can I have a time check, Suzie? All right. So, and I'll give you a quick example. I get a call from a provider, and they tell me, hey, I just had an encounter, and I think I could have done a better job. Can I talk to you? I'm like, wow, this is good. Talk about self-awareness. We meet, and starts telling me what's going in the situation. Somehow they get into a conversation. He's looking at Epic, and Epic in the test and all of that, and in the medical history, it's saying, you're an alcoholic. The patient is saying, that's not me. And the physician is working through, no, but look, you've already talked to us about this. We have your tests here. We have your story here. Look, it's you. No, that's not me. That's not me. It's an African-American woman, the patient, nurse from Piedmont. So he goes back and forth, and ultimately the woman says, listen, that's not me. Let's take a look at this thing the right way. What's the name that you have on that test? Oh, same name. What's the middle initial? Same middle initial. Same last name. Same year of birth, same month of birth, 1 digit different in the day of birth. Epic had mislinked the test. It was not her, and he didn't believe her at any point. He felt so terrible. That's what prompted the call. And the only reason he became aware is because he saw the proof that he was wrong. But do you think that was the bias? Bias wasn't there. When I'm talking to him, I say, what's going on? So tell me a little bit about your day. Well, first of all, so how do you start your day? Boom. I get up, I read all my charts, so when the patients come, I know everything about my patients. I'm ready for the patients. But with ServiceNow, I get patients that at 9 o'clock get an appointment to 11. So I'm not ready. And that frustrates me. He's not even thinking about the whole thing with a patient, with a nurse patient. He's only, just by happenstance, he's telling me, and you know, that's at so many levels wrong, but let's not even talk about that. Let's go back to the issue at hand and the interaction. I said, well, your true issue was you already came into that interaction biased because this was a patient that took advantage of an appointment today. And we, as a system, are inviting patients to do that because we want to provide the best service. You're thinking it's an imposition on you. That's what you got to work on. So these are the effects of bias. So let's, quick video here, microaggressions, because if bias is not enough, let me tell you, they typically come out with, microaggressions too. So let's do this, and hopefully I should be able to do this right.
For people who still don't think that microaggressions are a problem,
Oh, you're so well-spoken.
just imagine, instead of being a stupid comment, a microaggression is a mosquito bite.
Ugh, it's a compliment.
Mosquito bites and their itch are one of nature's most annoying features. But if you're only bitten every once in a while,
No, where are you really from?
Cleveland.
sure, it's annoying, but it's not that big a deal. The problem is that some people get bitten by mosquitoes a lot more than other people. I mean, a lot more. Whether it's on a date,
Oh, your English is so good.
Excuse me?
going grocery shopping,
You know, everything happens for a reason.
Just buying apples.
commuting to work,
So when are you gonna have a baby?
watching TV,
We have to keep the Redskins name part of our culture and history.
or just walking down the street with your partner.
I couldn't even tell you were gay.
Mosquitoes seem to pop up everywhere.
You know, John, shopping is so fabulous.
Of course, beyond just being annoying, some mosquitoes carry truly threatening diseases that can mess up your life for years.
Astrophysics? Maybe you should try this challenging major.
Ow, my dreams.
And other mosquitoes carry strains that can even kill you.
He looked like he was up to trouble, okay? I felt threatened.
So next time you think someone's overreacting, just remember, some people experience mosquito bites all the time.
You're all so exotic. Wow.
And by mosquito bites, we mean microaggressions.
These subtle messages that ultimately demean people. I think we're going to reduce the Q&A here. All right, so these little messages. Any reactions to that? Have any of you experienced? Raise your hand if you've experienced a micro inequity or microaggression like this. If you feel comfortable in sharing, can you share one? Stay-at-home mom. Oh, I love that. And stay-at-home mom, we got a call from someone who always gets to, and I confused that. I heard moms versus I have no kids. So let me roll with that example, and then we'll go to the stay-at-home mom. So I get called from one of our teams, and we're shift and holiday comes around. And in the summer, I always get told by my supervisor, well, why don't we let the people that have kids take the summer vacations? You can take them in, I don't know, October, September, once the kids are back. So this person tells us, you know what? I like the beach in the summer too, right? So that's one example. Stay-at-home moms, and there's always the difference. Or when you're in, you come to meetings and then, so then what do you do? Well, meetings at the office, right? So I'm the chief diversity officer, and your wife, she's a stay-at-home mom. Like, people don't say anything, but they actually hit the brakes and they don't know how to react. So other examples. Yes. You speak so well and articulate. Do you know why that's an issue? I'm going to, way back there, your hand was raised. Us? All right, so you were talking to a lady about the kind of loans for housing, and she automatically assumed?
That I was referring to HUD instead of FHA.
Right? And this happens all the time. This is so frequently. It happens to our patients, right? When we say Mr. or Mrs. in our clinics, and then someone completely different it comes up, right? Let me tell you 2 stories, and then we'll go into the more here in the audience. So we have a patient in the women's services. Let's say his name is John. So he's waiting. John gets up, male presenting, and it's pregnant. You know what the other patients in our waiting room did? They were looking at a pregnant man. I got to take a picture of this. Right? And, by the way, then it really got awkward when people didn't know what to do at the desk, and the nurses and so on and so forth. So that's why we're putting up a lot of we're starting to train on standard training and so on. But quickly, you can delegate, you can immediately, show reaction of that's not good to do. But pictures, we handle that. We tell patients every day, you can't take pictures here. It's a privacy issue, so on and so forth. Here's another one. Lynn Buzzing. And I think I'm pronouncing it right. Buzzing or abusing. Is it buzzing or abusing? Who knows, right? Buzzing. Let's go with Buzzing. Lynn Buzzing. Miss Buzzing? Buzzing gets up, frustrated, goes back. Miss Buzzing, after 3 times being called Miss Buzzing, emails me. I don't know. Well, I do know. When on the website found, emails me, and Miss Buzzing says, you know what? I'm tired of you guys misgendering me. All you got to do, he didn't say take a pause, but all you got to do is look at the chart and understand that I'm a man. All right. So Miss Bussing, that we always greeted with Miss Bussing, goes in again, talks to the doctor, gets testosterone therapy. He said, we're going to hook you up, we're going to refer you to an appointment. His appointment goes into my chart, sees his appointment in November with an endocrinologist. A week later, he gets a message, goes in, sees the appointment canceled, and rescheduled with an OBGYN. All right? So he shoots an email and says, hey, wait a minute, my appointment has been rescheduled. How come? Then comes, and I notice it's with an OBGYN. Our OBGYN responds via my chart and says, Bussing, if you're looking for gender-affirming hormone therapy, I'm your specialist. I'm here to help you in everything you need. Miss Bussing, Lynn Buzzing, his name is Lynn David Buzzing, is a 71-year-old straight white male from rural Georgia. So in his complaint to me, he says, and now I know, by the way, not only you're misgendering people all the time, you're also just handing out gender-affirming hormone therapy like that without even checking. That's what a little bias of Lynn David, I don't read the second name. Lynn, it's got to be a female. I'm used to it. So do we all have biases? We all have these kinds of associations, friends. All right, I'm not going to go through this nor this. I'm just going to jump into this. So how do I address these things? A couple of methods here. One, the XYZ. I feel X when you do this because of Z. And we'll give you an example in a minute here. Microaffirmations, you can also then, as opposed to be on the side of receiving or perpetrating micro inequities or microaggressions, make sure you also think of microaffirmations, small messages that make people feel good. Like when you're in a meeting and someone says, this was Mike's idea, this was Jennifer's idea, this was Tawana's idea. Tawana feels pretty good. She might not show it, but Tawana feels pretty good. At least Tawana in my team, because I know she doesn't mind public acknowledgments, right? Or calling people in. You can call people out like you would need to in the situation with pictures, right? But I suggest calling people in. Hey, did you really mean this joke? In this. So let me share with you some of the scenarios. I feel uncomfortable when you ask me where you're really from or where I'm from because it makes me feel like I don't belong here. You saw the example in the video. So that's how you make. So you talk about the behavior of the person. You don't call out the person. The next one is, right, how you can do microaffirmations. You can say, hey, team, I'm probably missing something. I need your brain trust. What am I missing here? That kind of actions. Asking questions, attribute ideas, as I mentioned, listening. And the best one, the most simple one, pronounce people's name the right way. Remember the names of your team members. You have no idea how many of you come and tell me after you've left the organization and I call you a year later and I tell you, where were you? Why did you really leave? My supervisor didn't know me. They didn't even know my name. They couldn't pronounce my name right. They didn't know what kind of research I did, so on and so forth. It impacts. Calling people by their name impacts them. Right. And then lastly, can we please have a conversation? So, hey, a quick call. Hey, I noticed that when you said this, right, were you really meaning that? I'm sure that perhaps didn't understand what you were saying or how it was impacting me. So bottom line, focus on the behavior, not the labeling. Appeal to the better instincts of the individuals. Make your views clear. Let people know that this was not right and didn't feel right for you. And if not in public, again, do it one-on-one. And in teams, if you lead a team, what I suggest is there's a team at St. Joseph that does this. They do the oops and ouch. When someone's talking in a meeting, doing something, and they say something that didn't sit well, someone says ouch. And the other person immediately knows to say, oops, I didn't mean to offend anyone. Did I say something? Did I miss something? And that creates what it potentially is a very contentious conversation. Brings down because we know we're about to have that conversation and we've agreed that there was no ill intent when we put this kind of assistance. So here's what I want you to do. In your tables, can you discuss examples of bias and or microaggressions, right? So you're going to share a little bit for 3 or 4 minutes, some examples, right, that either happened to you or you witnessed, and then you're going to also talk about how did you feel if it happened to you? How did the person feel, right? What's that impact? How did it ultimately impact you? So we all got the exercise? 3 minutes, 4 minutes. Let's share some examples. Let's go. All right, let's come back as a large group. I know the conversations are exciting. Anyone wanting to share?
So my microaggression situation was shortly after I finished nursing school, and I went in to assess a patient along with my nurse tech, and immediately the husband of the patient started talking to my nurse tech, telling them that they need pain medicine and all these things. And the nurse tech said, oh, I'm sorry, honey. This was in Virginia. I'm sorry, honey. She's your nurse. I'm your nurse tech. She was Caucasian.
Absolutely, we hear that. It's not uncommon. Other examples. And by the way, how did you feel?
I felt sad because this was in the 90s, and by now, we have a lot of educated.
So you felt sad, and it certainly impacted the rest of that day. Well, this was in the 90s, but in the listening sessions we did a year ago, we still hear that. We still hear, I don't want to be seen by the black nurse or the black doctor or so on and so forth. And sweetie, honey, can you get someone that looks like you to the white provider? If you're going to refer me to a cardiologist, can you get someone that looks like you and they pat him in the cheek? This is what our colleagues tell me. Another example. Yes.
Our table talked about the sensitivity towards names. So just by looking at a person's name and visualizing them different. Mm-hmm.
Absolutely.
Yes.
I always, every time, I'm introducing myself to anyone, I'm Ildemaro, González, and they say, oh, what a beautiful name. And I'm like, really? And then they go, do you have a nickname? Wait a minute, you just told me the name was beautiful. All right, another example.
Hi. So there was an employee recognition week, and I am Muslim, so I can only eat halal meat. And it was offered to get Chick-fil-A. And so everybody had Chick-fil-A sandwiches, but nobody came to me and said, hey, can you get another option or anything? So everybody else got food around me, and here I am sitting there. And they knew that I can only eat halal meat. So
absolutely. And this is how you little by little tell people you don't belong or we don't see you. Right? Or when it's iftar and then you're having meals in the middle of the day and you're not paying attention to the iftar dinners, Ramadan, so on and so forth. All right? Another one.
It's not, I was telling them the experience that I have many, many years ago, the first time I came to your country, to USA. As a tourist, I came because I wanted to see the Statue of Liberty. So I came, and then again, by mistake, in my country, I'm from Panama, and we don't speak English. But I have a magazine that said RN. So I went, and the immigration guy looked at me like this. What are you here for? Estatua, in Spanish. I don't know. And he started talking to me in English, and he looked at me and said, talk to me in English, you know that. You come in here to get married with an American to stay in this country illegal. I was like, what? At that point, I start crying, and I don't understand what he's saying. Finally, they give me the interpreter, and I call my friends in Panama. They work for the government in Panama, and I told them, screaming on the phone, they think I'm a criminal. So, because I have a magazine that said, yes, I'm a nurse in my country. So for many, many, many years, I said, I don't want to come to this country because the way they treat me. And I never forgot that guy in immigration, never forgot his name. So again, when you said when you come into immigration, we always shake, and they told me, do not change lane, do not look anybody because they know suspicious. Absolutely. So I said, I didn't speak your language, I learned it. And after many, many, many years, he said, okay, I'm gonna go. The first time when they invite me again, to be a team of Houston, whatever. And they said, oh, I don't want to go to America. There's these people there think we're criminals or whatever. So, exactly. And then after that, I said, I'm a straight person, I'm going to do it. And after 41 years of nursing, I'm here.
Awesome. So, what a great way to end here. So let me just make a quick point. How many of you, when you go through immigration, have to think about that? How many of you do not have to think about any of these kind of things when you're going through immigration? How many of you don't think about it? Raise your hand. Right? Because you're coming to your country, you're here, you have no problem, right? That's what privilege means. All right? Privilege is not this fancy thing. Privilege is I don't need to be concerned while others do. If I have, teen black boys learning to drive, I'm a little bit more concerned, and others don't have to be concerned that way. So last slide before we get you to the risk and legal here. Be an inclusive leader, treat people, right, and groups with fairness, leverage the thinking. Again, remember, it's about inclusion, not diversity. Leverage the thinking of the diverse perspectives, get ideas, enhance your actions by getting the ideas from everyone. Be intentional, design for inclusion from the get-go. Don't do things and then try to be inclusive. When you're putting your services, when you're putting your programs in place, design for inclusion from the get-go, stratify the data to understand who's being left out, ensure language services is available, practice microaggressions, take a pause. Remember on the example of the chair, take a pause. You know how impactful it can be. And lastly, check yourself and your decision criteria. Remember the example of the doctor that I shared with you? Was looking at the data, the patient was looking at the data, they were looking at the same thing from two different perspectives, and they were both right in their minds, right? So, to wrap up in this last minute, let's do 1 minute exercise. Let's everyone get up. Get it? Suzie, come up here. Get in a pair, Get someone in front of you, and this is what you're gonna do. All right? Position yourself like this in front of each other. All right? Yeah, I don't want to fall off. All right? And everyone on this side of the room, everyone who's looking to that wall, raise your hand. All right, you're going to be A. The other person's going to be B. All right? If you're looking at that wall, you're going to be A. The other person in front of you is going to be B. All A's, please do this. Lower your hand and point to the nose of the person in front of you. And now you're there. Now you're going to raise it a little and turn it clockwise. So 12, 3, 6, 9, 12. Now we're going to do it smoothly, right? 12, 3, 6, 9, 12 in circles. It's turning. A's, how is it turning? Clockwise, right? It's turning clockwise. B's, how is it turning? Counterclockwise. Same action. All right, now everyone can look at me. Same action from a different perspective generates two different results, and they're both true. So next time you're stuck in there fighting with your patient or your boss, take a pause and say, wait a minute, should we all look at this from a common perspective? Why don't we all get on this side and look at here and understand? So it's about perspective, and the world doesn't work only on your perspective. Thank you so much. Have a good afternoon.
Thank you so much. That was great.